So our afternoon session will begin with a tribute to Dr. Lucian Leape, created by Danielle Cameron, and a tribute to John Campbell by Sanjay Krishnaswamy.
So I was in the Mediterranean, received a telegram, which was all garbled. It had, I could see the letters ARD, and I decided that was from Men Harvard, and I'd been accepted.
I'd be proud to have the accomplishments that he's had. Not only was Dr. Leape one of the true leaders in the creation of the American Pediatric Surgical Association, was a founding member, but he also received the Distinguished Service Award from that organization.
I think the very great majority of us felt that we would not really be recognized as a specialty until we had our own organization. It seemed to us we needed to have standards, and we needed to have training programs. It seemed to us the only way to achieve any of those objectives was to set up an independent pediatric surgical organization that had some standard.
As he wound down his career in pediatric surgery, he went into his second career that has had as much, if not more, impact on the care of not only pediatric patients, but all patients in our country and worldwide.
Lucian changed the trajectory of where the field of patient safety went.
Patient safety problem at the simplest level is changing a practice like wash your hands, do a surgical checklist. But at the fundamental level, it's a cultural thing where you get people to feel comfortable about talking about their mistakes, being willing to think of them as systems problems, being able to work together to figure out how to change it, to recognize hazards before people get hurt, and have an environment where everybody's interested in doing something about it.
At a time when you never acknowledged that we were fallible in medicine, this was revolutionary, and that you put signs to it and said that good doctors across the spectrum could have a substantial rate of error that harmed people, that was very powerful.
It's hard to imagine anyone who's had the kind of impact he's had.
He'll show you what's possible, he'll open the door, and then you have to walk through. And he'll give you a whole lot of work to do along the way.
Well,
and I think, and what you've done, Lucian, for all of us, is reminded us at the core of being a doctor is making sure that we're delivering safe care to our patients and really align the mission of patient safety with the mission of being a physician. And it's hard to imagine anybody else who could have done that. So thank you.
Thank you for your inspiration. Thank you for being a friend. May you keep fighting the good fight.
You have to announce the next one.
There's the next one.
Can do the next chapter.
There should be a second tribute to Dr. John Campbell by Sanjay Krishnaswamy as well.
Born and raised in a small town in Kansas, Jack Campbell grew up as the son of a family doctor in the days when that meant delivering babies, setting fractures, pulling teeth, and taking out gallbladders. After training as a surgeon in Kansas, Jack's interest in pediatric surgery was cemented during his stint with the Navy when he cared for dependent children and their families. He subsequently moved to Philadelphia to train under C. Everett Koop. After finishing training at CHOP, Jack took out a map and looked for universities that did not have pediatric surgeons. That is how he ended up heading to Portland, Oregon in 1967. Starting from scratch, Jack built a practice and ultimately led the Division of Pediatric Surgery at Dornbecker Children's Hospital for 30 years, rising the academic ladder to Surgeon-in-Chief at Dornbecker and Chair of the Department of Surgery at Oregon Health and Science University. As was customary at the time, there was a cadre of community general surgeons operating on children. But when Jack arrived in town, the care of children fell solely on his shoulders. He took call alone for the next 10 years, operating at several hospitals in Oregon and the Pacific Northwest. Throughout his career, Jack innovated, There were no pediatric oncologists when he arrived, so after determining the proper regimes for childhood tumors, Jack himself would hang the chemotherapy. He implemented the double antibody assay for insulin and began performing subtotal pancreatectomies for hyperinsulinemia in infants, putting together one of the largest series in the early history of patients so treated. As a pioneer in minimally invasive surgery, in 1983 he published a large series of transcervical thymectomies in children with myasthenia gravis. He performed many innovative surgeries, but one of his proudest accomplishments was bringing TPN to the Pacific Northwest. He learned the principles of this new modality from CHOP and began using it for children with abdominal wall defects. Soon the formulations began appearing on the adult surgical wards of other Portland hospitals, taken there by his residents. Despite all of these innovations, Jack's favorite operation remained TF repair, and he fondly recalls one Friday when he operated on 4 newborns with this diagnosis in the same day. Continuing his tradition of education even in retirement, Jack and his family founded the Campbell Lectureship in 2008 to bring esteemed surgeons to Portland, welcoming his mentor, Chick Coop, as the first awardee. Over the years, 11 others have followed, exchanging knowledge and teaching students, residents, fellows, and faculty alike. Outside of work, Jack remains an avid fly fisherman and gardener. After retirement, his gardening focused on camellias. He is a member of the Oregon Camellia Society and certified as a show judge. He's the proud parent of 2 sons and a daughter, as well as 2 grandchildren. He has also remained an inspiration for each pediatric surgery fellow who has graduated from OHSU, many of whom have had the joy of spending a day fly fishing with him just before graduation, to hear his stories, garner his advice, and connect with our living history. Recognized by his peers worldwide, Jack was a founding member and president of the Pacific Association of Pediatric Surgeons and chair of the section on surgery of the AAP. In his role as a founding member of the APSA, Jack sends his greetings.
Happy birthday, APSA.
Okay. Good afternoon, everyone. We're so excited to have you here late in the day. I'm Loren Berman. I'm the chair of the APSA Quality and Safety Committee. I have Mehul, Raval up on the stage, along with Akemi Kawaguchi, Colleen Fitzpatrick, and Monica Lopez. And we're rolling out our toolkit that you might have heard about. So this is our opportunity to tell you more about it and hopefully generate some enthusiasm. And you can share it with people who aren't in the room. If you're in the back standing up, feel free to come up front. We want to make this very interactive and have a lot of discussion. So welcome. I have no disclosures.
I don't know if they have the buttons.
This is not the right slide. I think that was the first abstract presenter slide. Well, I can just try to do this off the cuff because I don't have too many slides. What I really want to highlight is our committee members sitting behind me who've been working really hard, really over the last 2 years. And where this all came from, I'll share a little anecdote. So a few years ago at APSA, Adam Golden presented what I thought was a really amazing and inspiring project on children who need enteral access. And he showed that by doing a pretty complex QI approach involving 3 years of gathering stakeholders, including parents as well as other clinicians, and developing the concept of a feeding tube medical home, and a preoperative checklist and standardized approach to postoperative orders, he was really able to reduce resource utilization in this very vulnerable population. So I left that APSA meeting and I was very inspired and I wanted to do it at my institution, but I just kind of didn't know where to start. I didn't have a lot of time, I didn't have a lot of resources, and Adam and his work in his group in Seattle had spent 3 years really making this come to fruition, and he was able to share the materials that he had already developed. So I didn't have to reinvent the wheel in Delaware. And we were able to bring the project to fruition in 6 months. And we've seen a similar decrease in resource utilization, and it's really changed the whole approach to enteral access in our institution. So the barriers that we encounter when we're trying to accomplish QI, how do you change culture? How do you gather the stakeholders? Who are the stakeholders? How do you deal with the naysayers? I was able to use not only the concrete order sets checklists, protocols that he developed, but also to use him as a mentor. And when I encountered a barrier, I would call him and he would give me advice about how to overcome it. So that's what our toolkit is all about. What we've done over the last couple of years is build a site. It now resides on a Google Drive. Dave Powell has been an incredible help to us in actually getting it onto the free channel of the Not a Textbook, as well as integrating links into the Not a Textbook chapters. So you can access content in 20 conditions. And I really want to highlight the actual site itself. Let me see if I just wanted to show you guys at least how you get to the toolkit. So the Google Drive site, Kemi's going to access it in a minute and show you what it looks like live. That's one way to get to it. You can not only get content from it, and these are projects that have been tried and succeeded in other institutions, and along with the protocols, you can actually get the contact information for the mentors who can help you deal with the inevitable obstacles you'll encounter. As I mentioned, it's also on the UPub free channel. And there's a great link on the new APSA website under resources. It's right on the front page there where the red box is. If you click, it will take you into it. And I'm going to let Kemi spend a little bit more time showing you around the site. And this is all accessible also on your mobile device, both the Google site and the free channel. So we're going to be having a lot of audience response. I don't know if you guys have your clickers, because I know you were told just to put them back, but we'll try for this. I'm going to try to keep you guys engaged. I know it's late in the day. The general format of the session is going to be very different than the usual abstract presentations. We're going to have an introduction to Kemi, who's going to, along with Colleen, share some content that we've developed as a committee on intussusception. Then Monica's going to share some content on appendicitis. And we're going to have a little audience response question to keep you engaged along with each abstract presentation as well. And what's unique about today is when you hear the great work that our abstract presenters are going to be sharing with you, they're also going to share with you the content that they've uploaded into the toolkit. So you'll have the tools to go back to your own institutions and try to replicate what they've done. So with that, I'm going to turn it over to this audience response question, if anybody still has a clicker. If not, we'll just maybe do show of hands. But we have a 22-month-old with intussusception who comes to the ED, has a successful air enema reduction. The baby is stable, belly is soft. Your next step is to PO challenge and discharge home. Do we have the audience response ready to collect? Admit for observation, and then PO challenge and discharge home from the floor. Admit to the floor, keep NPO. I don't see the timer ticking. Do you guys need to make the timer? All right, let's just do a show of hands. How about A, PO challenge, discharge home? A lot of people. Oh, it is working. Oh, there we go, okay. I don't know if anybody has clickers.
It's supposed to be the graph of how
would anyone, oh, okay. So we have a good spread. All right, so we'll keep that in mind and as you listen to Kemi and Colleen share our content.
Thanks very much, Loren. So our quality improvement project on intussusception really just stemmed from a desire to be able to safely discharge our patients home from the emergency room if they had a successful reduction of their intussusception. So we gathered some stakeholders, got a meeting together, and came up with a good protocol that was approved by everybody and then put it on the APSA toolkit. So could we put the computer on there? I'd like to show you that. Okay, so this is the first page that you would see if you were accessing the APSA toolkit. You can see that there's a variety of different topics. There's a lot of different folders that people have already contributed information to. And again, this is also available on the APSA website. So for us, we could click on intussusception. This is a very simple project. And you can see here that this blue box is a button that you push to get to the intussusception projects. Colleen and I are the owners of the folder, meaning we kind of manage the folder. And then these are people that have contributed their information, their quality improvement projects regarding intussusception. So if we click on the intussusception project, you can first see that there's 3 files across here. The first one is a master contact file. And what that is, it describes the projects, who put the information on the site, where they were implemented, and then also contact information for the person who implemented the project, so you can ask for help if you want information. This is just a file that has links to different manuscripts that we thought were pertinent and would be helpful for you to read. And the last file here is just a welcome to this toolkit page. So it has information on how to view it, what the folders are, and also if you're interested in submitting the projects and quality improvement work that you've done at your institution, you can also submit it yourself. So for what we did in Houston, is the way to know is this read first file is just a brief, let's see if I can get that a little bit bigger, has a brief description of the project that we did, and really we were working on early discharge. And it looked like about, half the people are doing early discharge, and there are a lot of people that are still admitting for observation. So we gathered our stakeholders of surgeons, emergency room physicians, nurses, and our radiologists, and came up with a protocol that was acceptable to everybody. And then here you can see that we did have some challenges in making that protocol. So the emergency room physicians, for example, were concerned that there was going to be an effect on patient flow if we observed them in the emergency room. So we came up with solutions where to have a short observation in the emergency room, and then if the emergency room were very backed up at a particular time, we could admit them to observation to offload some of the patients from the emergency room. And so the next thing that's on here, and these are freely available for you to look at as we speak. So this is just the actual protocol that we came up with. It's in our resident handbook. It's in the emergency room as well. And then we also came up with a flow chart that describes the pathway of a patient that's coming through the hospital, through the emergency room, and what kind of characteristics, who would get admitted, who wouldn't get admitted, and it has a protocol for how we do this. And so it's a really simple project. It was very easy to put together, and it's just something that we want to make sure that other people can do the same projects and not have to reinvent the wheel, or at least understand some of the barriers or challenges that could come up with such a project. Now, Colleen is going to introduce another intussusception project that's a little bit more complex from Boston Children's.
Good afternoon. So we will go back out to the page here, and if we go back to the main intussusception site, you can see all of the different protocols that have been uploaded. And as Akemi said, we were going to talk next about the protocol from Boston Children's, which also focuses on early discharge from the emergency department, but then also includes an element of patient follow-up. So you can see as you open to this page, there's more on the page than on the Houston site, but it's because it includes additional elements to the protocol. So again, there's the README first document, which we would anticipate seeing in every toolkit that gets uploaded, where there's a description of the protocol, and I'll zoom in here, we can see the stakeholders, and then challenges and solutions. And I think it's actually kind of interesting just to look at the first challenge here. I find that there's elements that we all encounter when we're instituting quality improvement projects, so issues with education, issues with getting buy-in, issues with compliance with the protocol. And the approaches that were used were very similar to what many of us do at our own home institutions: reminder emails, discussion at faculty meetings, or the use of resident orientation sessions. And so now we'll go back out to the page here. Their algorithm is listed here, so simple flow diagram similar to what the Houston site had on. Clearly both of these programs are working toward early discharge, but the algorithms are going to be slightly different. And what's nice about having different algorithms is that there may be elements that you might find from the Boston Children's that would work at your institution or from Houston, and you can make a hybrid and find something that's going to work for you. As I mentioned, Boston incorporated discharge as part of their protocol, so they have these nice family education sheets in multiple languages. So we have it here in Arabic, English, and Spanish. So nice education materials that can be used. And then they also have standardized phone follow-up, and they have a script that's used for that so that they're collecting the same data points with each of the follow-up phone calls that's made. And then what I really like about this toolkit is this last document here, which is an update, right? So quality improvement's an ongoing process. The goal is for us to institute protocols, collect data, see where there's room for ongoing improvement or refinement of the protocol. And so at the very bottom here, and I'm not going to get into the details, but presented in tabular and graphic form are the results of the institution, the results that that they saw once they instituted the protocol. And then based on those results, just above, they have next steps. So how are they going to keep making this better? How can we take this to the next level? And I think that's truly, the essence of quality improvement is we want to keep making things better and better as we go. And so not only are the toolkits here as a resource, but they're really here as a living document that's going to change over time as we continue refining how we take care of patients. And with that, we will take a look at the appendicitis page.
Can you go back to the slide deck? We just have one audience response question after this one. I guess I can
just show hands.
Is that good?
So we're going to have a break for questions before we start with the abstracts, but I just wanted to move on to appendectomy. So I wanted to hear from the audience, which of the following appendectomy care areas are you most interested in adopting into your practice? The choices are same-day discharge, intraoperative diagnosis standardization, clinical practice guidelines, limiting CT scan use, clinical decision support, and patient education. And then we'll hear from Monica about the materials we have available in each of these, some of these areas.
Oh, wow, that's great. Hi, everyone. Good afternoon. I'm glad that we have an understanding of what people's interests are with regard to quality improvement initiatives in appendectomy. It looks like a pretty even distribution of types of endeavors that people may want to pursue in adapting or adopting in their own institutions. And I'll show you the extensive information that we have compiled and organized within our toolkit with regards to appendectomy. And if we can please have the computer screen display, thank you. So once again, as you've heard from Akemi and Loren, this is the initial homepage to our toolkit, and we'll just begin exploring what's up there for appendicitis. There's a ton of information on here. This includes quality improvement initiatives, protocols, clinical pathways. They're really addressing all phases of the care continuum for appendicitis. And what you'll find is not only really specific and brief descriptions of individual projects, but also supporting materials that accompany the brief description of the project. And these may range from actual evidence-based guidelines and algorithms, also clinical decision support tools such as order sets and templates, and even patient education materials. And what I find really valuable is the easy access to the master list of content experts in QI who have actually developed these projects and implemented them, to whom you could reach out to for help and as you decide which of the protocols can be adopted in your own setting. So it's a little hard to see. I'll blow it up a little bit, but I've sort of organized it in terms of the preoperative, intraoperative, and postoperative phases of care for appendicitis. And for example, we'll have information related in the preoperative setting of how institutions have launched endeavors to decrease CT scan use. Also related to how others have enhanced the informed consent process for appendectomy. Intraoperatively, how some institutions have, for example, standardized the intraoperative findings with regard to disease severity. And in the post-op setting, we'll learn about how some institutions have created protocols for safe same-day discharge, as well as clinical pathways for perforated disease. So I just want to show you the type of materials that are up here. For example, under decreasing CT scan use, 3 institutions have contributed projects. I'll showcase the work of 2 of the institutions actually worked on designing structured reporting templates for ultrasound and appendicitis. And this is the work of Dr. Raval. And you'll find not only the descriptions, as you've seen in the other folders for intussusception, but also you'll see the actual format of what the structured template was that they designed, as well as the results. So you'll see either links to published data describing the successful implementation of the reports, or in this case, for example, there's a poster that summarizes how they've been able to have more accurate reporting of ultrasounds, decreasing CTUs, while maintaining balanced metrics such as a unchanged negative API rate during the implementation period. Now, with regard to people who have worked on enhancing the informed consent process at Texas Children's, people have worked on designing a visual aid that is used during the informed consent process to help parents understand and promote the understanding and their engagement during this process. So again, this is an example of how there's a link there for their manuscript that demonstrates the successful implementation of the project, but also you'll have a link to the actual visual aid that was utilized. It's really helpful materials that accompany those brief reports. In the intraoperative phase of care, institutions have aimed to standardize the intraoperative findings. So I'll show you briefly of the two places that have uploaded their protocols. I'll show you the one out of St. Joseph Children's, in which they've designed a checklist that actually allows the surgeon and the team to adjudicate the intraop findings with regard to, for example, the findings of perforated or a complex appendicitis, which then dictates what the postoperative pathway should be for these patients. And at Texas Children's, we've done something similar where we've generated these really helpful visual graphics that are posted in the operating room and at the areas where surgeons document their findings, where you can have both the descriptive findings and the visuals that corresponds to the various stages of disease severity, which can then be linked to have the appropriate documentation with regard to ICD-10 diagnoses and the appropriate wound classification, which we all know are very important not only for reimbursement purposes, but also, at least in our institution, for our own internal tracking of outcomes in our health analytics platforms that really relies on how the surgeon's documenting the disease severity. And then just real quick, let me show you what we have with regard to post-op setting. We have several protocols that people have implemented for safe same-day discharge. And again, it goes beyond the actual description of the barriers encountered to include things such as the order sets that were used, as well as specific telephone phone call scripted documentation that can be done in the EMR in the form of smart phrases, et cetera, with the elements that we found are critical to make sure that at the 24-hour phone call, our patients are being screened appropriately for any potential problems. For perforated appendicitis, we've collected multiple pathways. I'll just show you a couple out of NEMORS. I think it's important to not only have access to the guidelines or pathways that have been developed, but also understand the process. And I think this is a great example of people utilizing their NSQIP data to guide their efforts in generating pathways such as this one that allows the appropriate evaluation of patients presenting with suspected appendicitis. Others have relied on really robust processes for generating practice guidelines that entail systematic reviews of the literature with literature appraisal and generating consensus and evidence-based recommendations with grade type criteria attached to it that then are used to generate and inform the actual guidelines. These guidelines and these algorithms look like this. You can access them right here. And in this case, you can also learn about how these were seamlessly integrated into the EMR by linking order sets to ensure the guideline was readily adopted, and also decision support. For example, We've created templates for HMP and progress notes that include smart form elements that make it really easy to capture the data as the providers are drafting their notes. And on the back end, you can actually capture these data to be used as surrogates for adherence and compliance with the protocol. So I find all these materials are really helpful, and I hope they're helpful to all of you. I think we're meant to do this process as a collaborative sharing, and so we hope that you would also upload your protocols and hopefully adapt or adopt some of these into your own settings. I'll show you, well, Kemi, I think, showed you the master contact list, but that's right here in the front page, and you can see right away who the contacts are, and we're here to help, and hopefully you're as excited as we all are to continue improving the care of our children with appendicitis. I'll happy to take any questions now. Can we take questions?
Yeah, I think we can open it up for questions if you have any questions specifically about appendicitis or intussusception or about the toolkit in general. And again, I just want to emphasize, I think we see part of the job of the Quality and Safety Committee from here forward to continue to build and curate content and update it and add conditions and increase the content that we already have. We've shared with you some of the more well-developed conditions. There are some that just have 1 or 2 projects, and we're always looking to build more content so that we can disseminate all the great work that's happening across our institutions and just help facilitate uptake. So, yeah, we'd be happy to take any questions.
Yes, Chuck Bro, Grand Junction, Colorado. Just sort of a mechanical question about the toolkits. As institutions evolve in their protocols, do they modify their existing things, or do they add new ones, or how does that work?
So I think the vision is that, as I said, it's part of the work of the Quality and Safety Committee that we have a QSC member assigned to every condition, and you can see how much time and energy has been spent, building the content in these categories. So I think moving forward, it's a matter of continually reviewing the content and updating it, and reaching out to the institutions who've contributed content just to see if there are updates, and some of the content will be replaced over time. But it definitely is an evolving and moving resource. It's not static.
Yeah, and the beauty of having a platform like this is that we're able to update the content almost real time. Essentially, it is real time. And so if your center has embarked on a quality improvement project and you want to share with others what you've done, what this allows us to do is take things further than what you can normally include in a well-written QI peer-reviewed paper. This includes a lot of the tools, the real essentials of implementation that we would all individually have to recreate at our own centers, and repeat the process and reinvent the wheel over and over again for some of the most common QI projects that are out there. And so not only would we encourage folks to update the content, and we've assigned folks for that, but we would really invite any of you to contribute content to this and help us move it forward.
And I think it's also nice to have various iterations of protocols that you developed at your institution, to leave the old stuff there and update it to the new so that people can see how the process evolved throughout time and how you'd be able to change your protocol to work for your institution.
Any other
Mohammed
questions?
Emran, Corpus Christi, Texas. One of the questions that I've got is these are great tools for us as the surgeons, but a lot of the times we have teams that are composed of nursing staff and directors and so forth. Is there a way that they can get access to these drives as well?
This is free and accessible to anybody. You don't have to be a member of APSA. You don't have to be a surgeon. The Google Drive format is literally just a Google Drive. You need to have a Google sign-in, but if you Google APSA QSC Toolkit, it'll come up, and anyone can get into it, including the non-physician collaborators. In some cases, when we include our contacts, we've actually listed nurses or anesthesiologists or intensivists who've also been instrumental in developing the protocols. So some of the contacts aren't just limited to surgeons. So, yeah.
The other way that folks can access it, as Loren mentioned earlier in the presentation, is through the UPub website. And as you guys know, Not a Textbook is a subscription aspect of that site, but there's a free publicly available parts of our pediatric surgery presence on UPub. And it's simply a link that you can push a button, and it brings up all of these topic areas that are represented on the Google Drive, but nested within our Not a Textbook and UPub platform. And so these resources are available through that channel as well, even if you don't have a Google login.
It's hard to see if anyone's standing up at the mic, but if we don't have any more questions, we're going to transition into the abstract presentation. So the format for this is we can go to the slide deck again.
Getting off, yeah. Okay. You don't have to stay for this part. I thought, what's it?
So we're going to, Mehul and I have put together an audience response question that's relevant to the content of each abstract that's being presented. So we're going to just kind of query the room about your current practice, and then you'll hear the abstract presenter, and then we'll have a 5-minute presentation followed by 3 minutes of discussion. And again, what we've asked the abstract presenters to do is incorporate the content that they used in doing their project into the toolkit. So it will be available to anyone to access. So we are going to start with the next audience response question. What perioperative antibiotic are you currently using for stoma closure in a patient with no known drug allergies? So you can go ahead and start the timer. The choices are cefoxitin, ampicillin, sulbactam, cefazolin, metronidazole, none, or another choice that's not listed. And then while you guys are putting in your answers, we can have our abstract presenter coming to the stage to present the first abstract, which is, it's Dr. Hira Ahmad from Nationwide Children's Hospital, presenting decreasing surgical site infections in pediatric stoma closures. So it looks like we have a preponderance of cefoxitin.
So can we go back to the presentation now?
Oops. If you...
I think it's on Toolkit still.
If we go back to the slide presentation, we're not using the website now.
Yeah, presentation S40, Ahmed.
Stop clicking, please.
Can I just hit the arrow on this one instead of using this?
I don't know if it's projected on there. I think that's just for the website, so yeah.
Okay.
Yeah.
All right.
Here we go.
Thank you. So gastrointestinal operations in children represent a significant proportion of surgical site infections, with a reported incidence of 7 to 20%. Ileostomy and colostomy closures are particularly problematic, with an incidence of SSI up to 40%. We previously implemented a GI bundle at our institution in an attempt to decrease SSIs. The components of the bundle are listed on the slide. With this bundle, we reduced our SSI rates, our length of stay, and our hospital charges. This is a run chart borrowed from industry statistics. It's an infection rate represented over time. The control limits are set by frequency of patients, and as the numerator decreases or the denominator increases, the control limit gets narrower. We implemented a GI bundle starting in 2014 and had a starting infection rate of 21.4%. With the implementation of the GI bundle, we decreased our SSI rates to 7.9% with a 63% decrease. We wondered if we could do better though. So we reevaluated our GI bundle and decided to focus on one component, the preoperative antibiotics. Our questions were the organisms in the infected wounds resistant to the preoperative antibiotics given? And if so, would changing these preoperative antibiotics reduce our SSI rates? We therefore looked at all of our ileostomy and colostomy closures. We identified SSIs using the standard NSQIP criteria. And for all patients with documented SSIs, we reviewed their pathogens, their sensitivities, and preoperative antibiotics used. Of 53 patients that we found with documented SSIs, 49% patients had microbiology and sensitivity data available. Reviewing the sensitivity data, we found that 15% of infections were caused by Enterococcus, which we know are resistant to cephalosporins, and 30% of infections were caused by E. coli, which were resistant to cephalosporins at our institutions. But both were sensitive to ampicillin and sulbactam or Unison. Therefore, starting in April of 2017, we changed our preoperative antibiotics to ampicillin sulbactam or Unison. And we noticed a statistically significant decrease in our SSI rates from 7.9 to 2.2%. This was another 72% decrease in our SSIs. So we started at 22.4, decreased it to 7.9, and with the implementation of the preoperative antibiotic change, we decreased it further to 2.2%, with an overall decrease of 90% since the baseline. We had one infection over the 1-year period that was caused by Staph aureus, which was resistant to Unison. So in conclusion, we previously showed that a GI bundle reduces SSIs in pediatric GI operations, and with one additional process change, we further reduced our SSI rates for stoma closures. Should we open for questions now? Okay. Just going to review our toolkit. So this is a brief description of our protocol, the stakeholders, the challenges, the solutions, as well as all of our literature. We also have specific guidelines for our colorectal patients, which are outlined here. These are the specific components of the GI bundle, and I'm sorry I'm going through this fast because all of this information is already uploaded on the website, and the steps of the fascial closing protocol. We also had various presentations with at RN orientations, at the RN education day, at the resident orientation day, and all of these reviewed specific guidelines for all the colorectal patients. We also made these pocket handouts and for education and also for constant reminder for patients to reference back to, or not patients, but the trainees and the RN staff to reference back to remind themselves of what the antibiotics are and when we use them. And with that, I'll be happy to entertain any questions.
Do you have any questions from the audience? Is this still working?
Yeah. I have one real quick question. Did you guys limit the number of post-operative doses? Like, what's your normal regimen? And then also, were neonates included for stoma takedown?
At our specific institutes, because these are mostly colorectal patients, ARM and Hirschsprung, we didn't have any neonate patients because usually we close their ileostomy and colostomy down the road in like 6 to 8 weeks. To answer your first question, we give preoperative antibiotics within 30 minutes of the incision, and we usually give them 2 more doses post-op.
Hi, Aaron Cunningham, Portland, Oregon. Very cool study. I really enjoyed how you took the iterative process of quality improvement and put it into good use. My question is about your case choice. Why just stoma closures? I feel like there's a significant amount of SSIs associated with like all the broader colorectal procedures in general, and so why just those?
Thank you for your question. So at our institution, we had our infection rate or SSI rate for stoma closure was particularly high, which is why we decided to focus on those patients, especially in our colorectal department.
Donald Nass, Boise, Idaho. Did you do any irrigation of the wound? It was saline, betadine, antibiotics?
We did not use, we usually just irrigate with saline before the fascial closing, and the steps of all of those is listed in the fascial closing protocol, but we don't use antibiotics for our irrigation.
Just a quick question about going to Unison for all those patients. Did you have to get a clearance from your ID colleagues to start using Unison for all your patients?
Yes, thank you for the question. It's a great question. We did, project was done in collaboration with our infectious disease department, and we actually reviewed all of these pathogens and their sensitivities with a couple of our ID physicians before implementing this change.
Okay, great.
Thank you.
All right, if we can have the next audience response question up. Maybe the next slide for S41. All right, great. So this has to do with our next presentation, and the question is, do you routinely discharge patients home on the same day after elective lap choles? Yes or no? While you guys are responding, I'll introduce our next speaker. This is Dr. Andrew Ye. He's presenting Enhanced Recovery After Surgery Protocol for Pediatric Laparoscopic Cholecystectomy and how we can promote early and safe discharge. Is there a password on that? Okay. Andrew, you've got a challenge ahead of you. 2/3 of the audience does not support same-day discharge for lap chole.
So we press the triangle to advance, and it's just up there.
Okay. All right, if we could pull up Andrew's presentation, S41.
Good afternoon. Thank you for allowing us to present our work. We have no disclosures. In the adult population, patients that undergo an elective laparoscopic cholecystectomy are typically discharged on the same day of surgery. However, at our children's hospital, historically, patients that undergo an elective lap chole were admitted overnight for observation. The goal of our project was to implement a standardized protocol for care in patients that undergo lap chole with the goal of promoting same-day discharge, thereby reducing unnecessary overnight hospitalization, improving patient and family satisfaction, and ultimately maintaining good outcomes. Our protocol was designed in collaboration with anesthesia, nursing staff, and our EMR people, and begins in the preoperative clinic. The next two slides are segments of the toolkit that we have uploaded online. In the preoperative clinic, the patients and their families are counseled that the goal after surgery is to be discharged on the same day, as long as these patients meet certain criteria. Namely, they're able to ambulate, they can tolerate a diet, and their pain is under control. As well, at the preoperative clinic visit, patients are scheduled for as early of an OR start time as possible to allow adequate time for the patient to recover in the PACU. On the day of surgery, emphasis is made on prevention and control of postoperative nausea and pain. In terms of nausea, patients that are at high risk for postoperative nausea are given a scopolamine patch in the pre-op holding area. In the operating room, the patient receives steroids at the start of the case and Zofran at the end of the case. In terms of pain management, emphasis again is on multimodal pain management with the goal of reducing opioid use, using peripheral nerve blocks, IV Tylenol, and IV Toradol to control their pain. This continues in the PACU, and if the patient reaches all criteria, they are discharged home. We implemented this protocol towards the end of 2016 and wanted to look at our outcomes in patients before implementation and after implementation. In the before implementation group, we had 105 patients, and the after implementation group, we had 145. In terms of patient demographics, there were no major differences other than in body mass index. In the after implementation group, the BMI average was 26.6 compared to 24.2. In terms of outcomes, as you can see in the fourth row, same-day discharge rate increased significantly from 1.9% to 77% in our after implementation group. As well, you can see with our surgery start time in the first row, surgery start time was significantly earlier in the after implementation group compared to before. As well, you can see that our ED 30-day return visit or 30-day readmission rate was no different in the before or after implementation group. We also looked at perioperative opioid use before and after implementation and found that after implementation, there was a significant reduction in opioid use in our patients. Lastly, we wanted to look at, within our after implementation group, what were the characteristics of patients that were admitted for an overnight hospital stay. And we found that those patients tended to have a higher ASA class, longer operative times, and a later surgery start time. So to conclude, our protocol for elective laparoscopic cholecystectomy led to a significantly increased rate of same-day discharges while decreasing our opioid use and maintaining low levels of complications, readmissions, and ED visits. In our after implementation group, patients that were admitted tended to be sicker and have later surgery start times, and that's one potential future improvement that we can make. Thank you. I'd be happy to take any questions.
Andrew, did you want to show anything from the toolkit?
I have it uploaded online, but did not have the...
While we take a question, if we could switch to the online website, that would be great. Kurt?
So, Kurt Heiss, Atlanta. Nice presentation. Can you tell us a little bit about important steps you made in implementation of this in your team and your institution? Every time you start a new semi-enhanced recovery type thing, it requires some adjustments. What were the inflection points as you worked with your team to make this happen?
I think the most important thing, as with all these QI projects, I'm sure, is gathering all the stakeholders, getting everybody on the same page, and working towards the same goal, including not only just the anesthesia staff, which is obviously very important, but also nursing staff, and also the EMR people that helped us make a very easy-to-use power plan that residents that rotate in and out of the service can use quite easily and follow the protocol. Let's see here.
And then Andrew, I had a question I'm sorry, please go ahead. It's hard to see you guys out there because the lights are blinding.
Rashida Skepta from Cincinnati. Quick question. The patients that you had, were they actually discharged from the PACU, or did they actually get admitted to the floor? Because for us in our institution, there's a significant cost difference for patients that are actually admitted to the floor as a 23-hour admit. And you don't utilize that same cost savings if you can if you have to admit them to the floor.
Yeah, they were discharged from the PACU.
It's a very nice protocol. Thank you. It says that you're admitting the average start time was 10:30 in the morning, but then your average length of stay was 13 hours. So are you discharging them at 11 o'clock or midnight?
Usually no. I think that's a result of the statistical analysis, and I think they usually go home early evening, around 6 o'clock at the latest.
Andrew, I had two questions while you pull up the toolkit there. One is, did you guys stagger the Tylenol and Toradol that you used intraoperatively such that in the postoperative setting, in the PACU, they weren't waiting a full 6 hours before they could get additional doses of those medications? That's something that we're struggling with when we're doing a similar same-day discharge for appendicitis protocol, and that's one of the things that we've been very thoughtful about. Did you have to do anything along those lines?
We didn't, but I think that would be a great addition to the QI project, and it probably would reduce opioid use even further if we could actually stagger out the doses of Tylenol and Toradol.
Okay, and then the second question was for your sickle cell patients. Were any of these patients sickle cell patients with prior opioid exposure and higher pain requirements? Were you able to successfully get those patients home the same day?
That's a great question. I think there were a couple of sickle cell patients in the implementation group, but I would have to go back and look at that. But they were included in the study.
We'll take one more question, and then we'll let Andrew showcase his toolkit.
I enjoyed the presentation. I just wanted to know, when you send these people home, do you give them any narcotics, or is the decreased use because they don't need them?
They are given a very short course of narcotics, but they're also given a script of ibuprofen and Tylenol and instructed to use those before. But yes, they are given a small short course.
Just a quick run through of your toolkit would be great.
Sorry, I'm just looking at the wrong one here. So this is the overview of our protocol and the stakeholders, the challenges that we encountered. And then I'm trying to find the other one. I don't see it up here. Huh? It may not have been uploaded properly. But the other document is basically the flow chart and the dosing in terms of when we give medications and which medications we give. And I'll make sure that's uploaded properly.
Thank you.
Thanks, Andrew.
If we can go back to the audience response questions for S42. Do you routinely prescribe opioids after appendectomy? And the answer choices are yes for simple or acute, yes for complicated or perforated, for both, for neither, or it depends on the age of the patient. So if you want to start the timer on that one, and as you guys are entering your answers, we will invite Dr. Molly Friedman-Weiss from Yale, who's going to be presenting an evidence-based guideline for post-appendectomy analgesia, opioid-free for most. So, the green one is. All right, so it looks like the most popular choice is nobody's prescribing opioids. We heard that a little bit earlier in the day as well. So we'll switch to Molly's presentation now, S42. Thank you. Yeah, it's gonna come up right just right now.
Thank you for the opportunity to present our work, and thank you all for sticking around. I think within this room, it's well established that there is a problem of opioid overprescription after surgery. Knowing that 90% of drug addiction starts in teenage years, this study demonstrated that for the adolescent population, seen here in red, 25% receive the opioids they use recreationally directly from one of their doctors. So we looked at how surgeons prescribe to children and adolescents. From our group's previous work, we found that for laparoscopic appendectomies, which are done by both pediatric and adult surgeons prescribe significantly more opioid to their patients. This wide variability found in pediatric prescribing may actually point to the issue of a total lack of opioid guidelines in the pediatric population. So we asked, are pediatric surgeons under-prescribing? How much opioid is actually needed? All with the aim to create a guideline for analgesia after appendectomies. To do this, we studied appendectomy patients who were less than 20 years old over an 8-month period. To account for complicated cases, we only looked at patients who were done laparoscopically and who were discharged by post-op day 2. Each included patient underwent a chart review for data such as inpatient opioid use, discharge prescriptions, and any post-discharge calls or visits for pain-related problems. We also attempted phone contact with each included patient to interview the care provider about the patient's medication use, their pain level, and their desire for an opioid prescription if they did not receive one. We used the Veterans Pain Rating Scale and classified pain greater than a 4 as being poorly controlled. Of 138 possible cases, 77 patients were consented, of whom 73 ultimately qualified for the study. These 73 patients were on average 12.1 years old and were discharged by post-op day 1. 49 patients were successfully reached for phone interview, while 24 underwent chart review only. The 49 interviewed patients had a mean age of 11.8 years. Of this cohort, only 7 received an opioid prescription on discharge, of whom only 4 actually filled and used their prescriptions. Of the 42 patients who did not get an opioid prescription, only 5 described their pain greater than 4, though only 3 felt like they would have benefited from an opioid. Putting this all together, 14% of patients either benefited or felt that they would have benefited from an opioid after surgery, while 86% were fine without an opioid. Taking a closer look at these patients, only 5 patients used an opioid after discharge at home. On average, they used the equivalent of 3 pills of oxycodone, though 90% of all patients used acetaminophen or ibuprofen at home. The 7 patients that benefited or would benefit from an opioid were a bit older, with a mean age of 15.8. 6 of them were male. The majority used an opioid while inpatient, and they were discharged early after surgery. Importantly, 0 of the 73 included patients called or presented for pain-related issues. This is in the setting of 88% of them not having received an opioid. Ultimately, we came up with these guidelines: acetaminophen and ibuprofen for all. And if based on a discussion with the patient and family, an opioid prescription is given, to prescribe the equivalent of 3 pills of oxycodone. Further, it would be reasonable to also have a 0 opioid policy with the understanding that 10 to 20% of patients may have poorer controlled pain. Now, our guidelines stand in stark contrast to recently published appendectomy guidelines recommending 10 pills of oxycodone. If our guidelines were to be used and say 20% of patients got a prescription for 3 pills, then nationally, in the course of a year, over 600,000 fewer pills of oxycodone would be prescribed. Now I'll spend some time going over the materials in my toolkit. Our IRB was a little bit different in that we first offered patients a way to opt out, and then we had a verbal consent script for patients and caregivers, as well as an assent script should we have chosen to talk to the children themselves. Aside from the IRB, we had welcome letters for the study, which were provided to rotating interns and residents as smart phrases in our EMR. The welcome letter included information about the study and a way to opt out. Uploaded also is the script that we used during the phone calls and the data that we collected, including our verbal consent for parents and caregivers. Lastly, at our institution this past year, we've developed our own procedure-specific guidelines in the form of a pocket card for each resident, and we'll include the new pediatric appendectomy guidelines in this coming year, which I've highlighted in red. This also has instructions for daily acetaminophen and ibuprofen use. On the back side of the card, we also, in red, have access to smart phrases for residents to use in discharge instructions, providing safety and disposal information for patients who are prescribed opioids. I'd like to thank my study collaborators, and I'd be happy to take any questions.
Thank you. That was great work. I had a question as people are making their way to the microphone. You mentioned in your recommendations that there should be a conversation with the family in order to determine whether or not to give them those 3 pills. And I'm wondering if there's a script for that conversation or how you approach that if the child is able to participate in the conversation versus not. It did seem like the more high-risk patients were the older ones.
Yeah, I think some people feel comfortable having a prescription on hand, either to fill and not take, or to fill if they feel like their child needs. I do think the parent or caregiver, no matter what, should be involved in this conversation. It's been a little bit easier at our institution to hold off on writing a prescription in case somebody needed it, because over the last 2 years in the state of Connecticut, we have electronic prescribing for opioids, and that's brand new. It used to be all paper prescriptions, so they would have to present to the hospital should they be in uncontrollable pain. We see that the uncontrollable pain doesn't really happen, but the fear is certainly real.
I'm curious as to how many folks in the audience have the ability to e-prescribe opioids now. Okay, so about half. I had a quick question about the pain scores. So it's a lot of work to call these folks and ask them about their pain scores. For the 5 to 7 or however many it was that ended up potentially being able to benefit from opioids, were their pain scores different than the remainder of the cohort?
Yeah, that was only patients who scored their pain greater than a 4. We used that veteran scale because it was actually quite easy to verbalize. It didn't require, smiley faces or anything, and you could describe it in terms of everyday activities. So it was patients who had a pain greater than 4, and then they were asked would they have liked to receive one. Most patients who had pain greater than 4 said it resolved within a couple hours.
Don Shaw in Los Angeles. We've been pretty aggressive about trying to avoid opioid prescriptions for a lot of our elective surgery, even in older kids. Lap choles, APIs, gastrocutaneous fistula closure. We have a discussion with the family ahead of time. We tell them we're worried about the opioid crisis and trying to avoid it. Tell them you're going to take Tylenol, you're going to take Motrin, you can use ice packs. It's going to be sore for a couple days and you're going to get a lot better. And then we really do ask the family, would you like us to put his prescription in? And quite often they say, no, we'd like to avoid it at all costs. So it actually does work, but it does take the preoperative discussion with the family, setting the expectations. Great work.
Thank you for that comment. I think that's a really great idea to start talking about it preoperatively.
Great.
Thank you.
Okay, if we can have the audience response question for S43. And this relates to antibiotic stewardship, as was highlighted earlier today. The question is, do you or any of your partners use preoperative antibiotics for pyloromyotomy specifically? Yes or no? And while we're waiting for that to pop up, I'll introduce Mark Cashton from Boston Children's, who's going to be speaking about implementation of a PDSA framework to reduce unindicated surgical antibiotic prophylaxis. Great.
This is our clicker. Yeah, green. The green.
Green ones go.
Just right there. Yep.
Thank you for our opportunity to present our work today. Current consensus guidelines do not recommend antibiotic prophylaxis in patients undergoing clean surgical procedures without foreign body implantation. However, there remains a high degree of practice variation in this cohort, with approximately 40% of children undergoing clean surgical procedures receiving prophylaxis. This high rate of unindicated prophylaxis is concerning, as overuse of antibiotics is associated with both adverse events and increased antimicrobial resistance. With these considerations, the specific aim of our project was to improve compliance with consensus guidelines and avoiding the use of unindicated antibiotic prophylaxis for clean surgical procedures. So this was a pre-post intervention study following implementation of a targeted education and auditing campaign. The impact of project interventions was assessed prospectively over a 10-month period and compared to a 6-month pre-implementation baseline. All patients undergoing elective clean surgical procedures without foreign body implantation were considered for inclusion, and patients with comorbidities associated with increased SSI risk that may have influenced the decision to administer prophylaxis were excluded. Following a Plan, Do, Study, Act framework, the plan stage of this project revolved around a surgical faculty meeting to review the consensus guidelines for prophylaxis, review baseline noncompliance rates, discuss reasons for practice variation, and establish consensus around the aforementioned exclusion criteria. The Do stage included sending standardized reminder emails to rotating residents and faculty with mandatory acknowledgement from residents to achieve closed-loop communication. For the study stage, audits were performed within 24 hours for all cases meeting inclusion criteria. Standardized emails were also used for this purpose with the goal of establishing reasons for noncompliance from the perspective of both the resident and the attending participating in each case. The emails also serve the purpose of ongoing education surrounding prophylaxis guidelines. Finally, the ACT phase involved modification of our interventions and further education based on both the direct feedback and the reasons for noncompliance that were identified during compliance audits. Noncompliance with prophylaxis guidelines was the main outcome measure, and this was balanced with 30-day postoperative SSI rates in both the pre- and post-intervention periods. This table illustrates the distribution of clean cases during the pre- and post-intervention periods. Inguinal hernias were the most common procedures, followed by soft tissue excisions and umbilical hernia repairs. The relative distribution of cases was similar between pre- and post-intervention periods. This control chart illustrates overall noncompliance rates with prophylaxis guidelines over time. Prior to the initiation of our interventions, our department-wide noncompliance rate was just over 40%, which decreased over an approximately 8-week period to a new baseline of 6.3%, reflecting an 85% decrease in unindicated antibiotic prophylaxis utilization. And importantly, this reduction in antibiotic utilization achieved here was not associated with an increase in the overall rate of surgical site infections. There are several important lessons we learned from this project. One was the importance of the in-person faculty meeting to creating a venue for discussing all perspectives and establishing consensus on issues such as exclusion criteria. Another was the role of residents who routinely prescribed prophylaxis without faculty knowledge. This resulted from residents' misconception that prophylaxis in children is expected and highlights the importance of early education on our trainee rotations. And third was a lack of improvement that we saw particular to breast procedures. This most likely arose from confusion over the SSI risk associated with these procedures, and those trying to emulate this project should incorporate education specific to this topic in their initial faculty meetings. For hospitals interested in replicating this project, we have developed our set of resources dedicated to that purpose within the antibiotic stewardship section of the APSA Quality and Safety Toolbox website. These resources include a read first document that serves as a master outline for the project, including a detailed background and overview with step-by-step descriptions of our rollout strategy to help with implementation at your institution. They also include a copy of the PowerPoint presentation used at the faculty kickoff meeting, which includes summaries of relevant background materials and consensus guidelines, uses data to identify high priority targets, and can serve as a centerpiece to build consensus with your colleagues and partners ahead of implementation. There's also an auditing spreadsheet that will allow you to easily collect all the information necessary to track cases, identify non-compliance events, conduct root cause analyses, and calculate your outcome measures without having to dive back into chart review at later stages of the project. The toolbox also includes standardized email templates for both the resident and faculty communications described in this presentation, and these will allow you to streamline much of your communications surrounding the dissemination of guidelines and conduction of audits for non-compliant cases. There are also links to the reference materials underlying the project, such as the consensus guidelines and background studies. And lastly, of course, is the contact information for our group, so you can reach out to us with any questions you may have as you prepare for and implement this project at your institutions. Once again, thank you for the opportunity to present our work.
Frida Holka, Arena, Nevada. I was curious, when you implemented this, did you include the anesthesiologist in discussing this? Because in my institution, the antibiotics are given by the anesthesiologist before you even say anything. So I was wondering if that was a part of why there was still some failures in the post-induction or post-project.
That might be a little institution specific there. At our institution, either the surgeon or the surgical resident has to prescribe it before the anesthesiologist can give it. So our interventions focused on surgical faculty and residents.
Chuck Bro, Grand Junction, Colorado. This is maybe more of a question for the moderators because of your clicker question that you put up there about pylorotomy. You presented indeed all clean cases, and all of us want our pylorotomies to be clean. But every now and then, very infrequently, there's a duodenal mucosal perforation, and then you have a clean contaminated case. I give 1 dose of cefazolin prior to my pylorotomies in that sort of case. What are your thoughts about should pylorotomies be prophylaxed, or if you do have a duodenal mucosal perforation, what do you do at that point?
Well, it's a little bit of a interesting selection of which procedure we picked. We picked pylorotomy specifically because we were expecting a little bit more controversy in regards to use of antibiotics as prophylaxis for that case. I'd be interested to hear from other members of the audience to see what the argument is against it. I think that ultimately I don't know if I know the specific perforation rate for a laparoscopic pylorotomy these days off the top of my head, but I'm assuming it's going to be 1 to 2%. And so for every one case that may occur, 99 children are going to receive antibiotic prophylaxis. I think that the cost-benefit ratio there tips towards not using antibiotic prophylaxis, at least in my mind. Eager to hear if anybody else has thoughts.
Did you guys consider pylorotomy a clean case?
We did not, and I think for the exact reason that was described. I think the controversy obviously is over the concern for potential for invading the GI tract. So
do all patients at your institution that undergo a colonoscopy get preoperative antibiotics?
No, they do not.
Thought. I don't know what the right answer is. But I do know that we are studying, we have a massive undertaking that Dr. Rangel mentioned this morning through ACS NISQIP, looking at antibiotic utilization across a variety of procedures. And if I'm not mistaken, and Sean, correct me if I'm wrong, but pylorotomy is still being selected, right? Is that a thumbs up? Yeah. And so we will have some data on that in the near future, meaning as early as this July, I hope, at our Quality and Safety Conference. And so maybe that'll be something we can look into as a organization and group. Great. Any other questions? All right, thanks a lot. Oh, sorry, one more, go ahead.
Derek Wakeman, University of Rochester. I actually asked Dr. Rangel this exact question a couple weeks ago, so maybe, I don't know if he's in the room, but I suppose at the risk of speaking for him, he did not think they were indicated, correct?
Oh, God.
I do actually have another just sort of interesting question. Does open rectal biopsy need antibiotics? Like, is that a wound or is it the same as colonoscopy?
So that's a super loaded question, but so we didn't consider it clean or not. We excluded it because, again, so can you hear me okay?
Yeah.
Because when we came to consensus for this project, and I mentioned this morning, we had to get everyone on the same page for buy-in. And everyone agreed more or less that this was too controversial that we would include. But the question is as Mehul mentioned, right? So if you have to give it 99 times for that one time where it actually perforates, that's not only all of the story, right? The second part of the story is, but you're probably going to recognize it at the time it happens. So you're going to give the antibiotic. So then what's the margin of SSI risk if you give it now? You don't have the tissue levels, but arguably it's not even going to be 99 to 1 to prevent one, right? It's probably going to be double or triple that. And so you really have to think about that. You can actually take that to the extreme too. And anytime you're in the belly for anything or near something important, you give antibiotics because of the possibility. And that's a judgment thing, and I think you all have to be comfortable with that decision. But as Mehul mentioned, so we are collecting that data as part of NSQIP. I think we already have 400 or 500 cases specifically of pyloromyotomy, and it's exactly 50% nationally. 50% give antibiotics and 50% don't. And the only thing that's the only procedure that's close to that is CVLs in ports, 50-50. And so that's where probably the two areas where we need some good comparative data. So.
Great, thank you. We'll move on to the next one. Thank you. So we'll bring up our last audience response question, S44.
So this is our last abstract of the session, and we'd just like you guys to answer, how often do you disagree with your NICU staff regarding need for postoperative narcotics? Rarely, sometimes often, and almost every single case are your choices. If we can start the clock. And we are welcoming David Grabsky from UVA. He'll be presenting reduction of opiate use in infants undergoing GI surgery. All right. Sounds
Very
like we have
good.
some work to do.
Hopefully this will be apropos.
You can bring up the presentation, please. It's just going to be on here.
Perfect.
Can you advance with the triangle?
Thank you very much for the opportunity to present. We have no disclosures. Over 4,000 neonates undergo surgery annually in the United States. For these patients, the use of opiates for postoperative pain control and sedation over prolonged NICU stays can result in high cumulative doses of opiates. There's growing evidence that neonates treated with high doses of opiates have diminished neurodevelopmental scores, as well as social sequelae in early childhood, which is and clearly this is gaining national attention now. Additionally, there are the known negative clinical effects of heavy opiate use, including respiratory suppression and delayed bowel motility. We implemented a multimodal intervention to reduce opiate use in neonates undergoing non-emergent gastrointestinal surgery in our NICU. Following multiple stakeholders meetings, including our pediatric surgical team, our neonatal team, and pediatric anesthesiology team, we agreed on an opiate reduction strategy, which included giving IV Tylenol for every 6 hours for 48 hours, in conjunction with a post-operative pain education seminar for NICU providers, and lastly, the inclusion of a pain control huddle for each patient at post-surgical sign-out with the NICU team. Our intervention involved all children who underwent non-emergent gastrointestinal surgery while admitted to the NICU. All ages and comorbidities were included. We used a historical control group to compare the effect of our intervention on the postoperative opiate use, which was our primary outcome. Secondary outcomes included postoperative neonatal pain scores, safety profile of our intervention group, and related clinical outcomes including length of postoperative intubation period, length of TPN usage, and postoperative length of stay. We had 72 neonates in our study group, 32 in the opiate reduction group, and 40 in the historical control group. Patient characteristics, including birth age, birth rate, APGAR scores, ASA scores, were all equivalent, as was the distribution of surgical pathology in the corresponding operations. This simple box plot highlights the cumulative postoperative morphine equivalence on the y-axis. The historical control group is denoted in blue, and the opiate reduction group is in red. As demonstrated by this data, we reduced postoperative opiate use by 98% with the use of our education intervention and standing postoperative acetaminophen. And I think the next two slides really tell the story. This histogram represents the exact same data. Again, our intervention group is in red and our historical control group is in blue. And what becomes clear from this data is that our intervention group reduced the significant heterogeneity in our postoperative opiate prescribing patterns in the historical control group and essentially collapsed them all into very low prescribing patterns that became uniform. Additionally, this histogram represents the percentage of patients that received a postoperative opiate infusion at any point in their care. Again, the historical control group is in blue, and as indicated, 80% of patients were placed on a postoperative opiate infusion in the historical group. Conversely, in our intervention group denoted in red, less than 20% of patients were placed on an opiate infusion. Importantly, NPAS scores, including medium and maximum scores, were equivalent between both groups. Additionally, the safety profile, including hepatic injury and acute kidney injury, were also equivalent. In addition, we also found that our intervention had a statistically significant correlation with a reduction in postoperative intubation from 28 hours in the historical control group to 3 hours in our opiate reduction group. This is very similar data where we found a 7-day decrease in the use of TPN postoperatively in our intervention group. In summary, we found that a provider education intervention coupled with standing postoperative IV acetaminophen effectively reduces postoperative opiate use in neonates undergoing gastrointestinal surgery. Despite a reduction in postoperative opiate use, postoperative pain can be effectively managed with IV acetaminophen. Lastly, our intervention appears to correlate with a reduction in postoperative intubation length and need for total parenteral nutrition. And like the other presenters, I'd like to go through the quality and safety toolkit quickly. If you click on the opiate reduction tab when you go to the website, it gives you the opportunity to then click on the opiate reduction QI project. It brings us to the Google Drive, and then you can see the UVA opiate reduction NICU tab, which just takes us into a pretty self-explanatory folder. And I think, like most of the groups, the most important aspects is looking at this read first project description. And I know this is too small to see, but one of the key aspects that I think is captured in this information is the key aspects of our protocol, which we think are necessary to duplicate this work at another institution. We also have challenges and solutions. The big challenge at UVA when we were doing this was getting approval of IV acetaminophen from our pharmacy group, which we have a little bit of detail in our toolkit. And additionally, we have several literature sources that we've used to create our protocol. And if you go to the protocol, just stepping through very briefly, we actually have an itemized list of our protocol as well as a PowerPoint presentation with key points to our intervention. Our order set actually includes our EPIC order set for IV Tylenol, including our dose-specific recommendations, and then as well as the pharmacy request document that we used when we were creating the QI project. The literature, and this is just for ease, these were four kind of critical literatures that we used when developing the protocol, and so if anybody's interested. At this point, I'd like to thank my co-investigators on this project, specifically Jeff Gander, who was the lead researcher, really championing this work. And I'd like to thank everybody once again and take any questions.
Hi, Derek Wakeman, University of Rochester. Wondering if you looked at unplanned reintubation. If you looked at our own institution, we've had a little bit of a challenge with that, and doing a deep dive, we've kind of felt that it's been due to oversedation in the NICU, and I wonder if there might be even another benefit that you're not aware of. You had decreased time of intubation, but I wonder if decrease in unplanned reintubation might be there as well?
Thank you for the excellent question. We actually looked, and the data didn't show any difference with reintubation, but I think it's an excellent point.
Hi, Jared McAteer from Anchorage, Alaska. This is a great topic, and I think that one that's very important. So I thank you for the study and the data. I had a question about the kind of the content of the educational program that you set up, because in my experience in the NICUs I've worked in, the big barrier to decreasing opiate use in neonates is with regard to the way opiates are prescribed. Often the nurses have standing orders to give pre-medication for whatever they perceive as being noxious, painful stimuli. So you'll see kids getting doses for silo reduction or dressing changes. And so was that something that you focused on as part of the education?
Excellent question, and 100% yes. A big part of our intervention was involving the nurses themselves in this quality improvement project. And so the education seminars were not just for the neonatologists, but also for the bedside nurses. And so they have a series of NICU education seminars that we gave several presentations with, just specifically for that reason, to involve them in this work, and so that they could really champion the idea of reducing opiates.
Thanks. Erin Raval from Lurie Children's. I serve as our surgical liaison to the NICU and was just in a meeting last week. So the toolkit would be very helpful for our hospital. Mehul, we have some work to do as far as the narcotics. But my question is, at that meeting, our lead pharmacist was there, and he had the data for our IV Tylenol use over the past 2 years and explained that each IV Tylenol dose was something like $23 compared to 4 cents for rectal Tylenol. And my question is, were any of these patients candidates for rectal Tylenol, and shouldn't we all potentially, as a cost savings measure, default to rectal Tylenol in any patient who could have that, especially in neonate, where it's really not traumatic at all for them to receive the medication that way?
Yeah. Thank you for the excellent question. 2 points. The first is that what ended up happening with us is I agree that on the $22 for a vial of IV acetaminophen, but what ended up happening is we used it for multiple uses. So one vial gave us up to 4 doses, which also helped offset the cost. It's also, as I understand, about to become a generic medication, which will help. Lastly, there was a randomized control trial that was published, I think in 2015, don't quote me on the date, where they looked at rectal Tylenol specifically in a randomized manner, and they didn't find an intervention, and yet IV Tylenol seems to be effective in our intervention. And so that's why we chose IV Tylenol. But I can't speak to it because clearly rectal acetaminophen has a role.
Great. Thank you. All right. Well, I just wanted to say a special thank you to our abstract presenters. You guys were kind of the guinea pigs in this process, and I would say there's no more effective way to get people to upload materials onto the toolkit than to say you have to present it at APSA, so maybe we'll continue this tradition. But I hope that you guys all have a sense of what this is and that you'll not only use it and use the mentors that have made themselves available, but also share the projects that you're doing and become mentors yourselves. And thank you all so much for your attention. That's it.